Hello, everybody. Welcome to Fertility Factor Fiction. I am your host, Dr. Rahi Victory, and I am back after holidays. So it's good to have you all on here. We'll just let everybody join, give everyone a minute to jump in. And unfortunately, we do not have Tarek with us, but we do have Natalie in his stead, and she's going to be helping us out tonight. So welcome everybody back to the show. And if you haven't been here before, this is the show where we answer your questions live and explain to everybody everything that we know about infertility. We answer your questions live, and as well, we do our best to try and inform everyone of exciting new things that are developing or around the corner. So, not a ton of new information out there. While I was on holidays, I did keep tabs, obviously, never rest, but coming out, one on letrozole for IUI and whether or not you should use progesterone afterwards. And the answer is yes, you should. We've been doing that for years and years and years, decades now. So I'm glad to see that that's finally out there. And then there is some new information coming out of the recent ESHRE conference that we'll review when more and more data comes out. So that'll be exciting when we get some studies and publications on it. So yeah, interesting stuff coming up and around the corner. Very excited about all that. Super excited to announce that Dr. Shireen Rahal has joined us, and our illustrious friend Dr. Tony Pattinson has retired. He's still helping out a little bit, but he is essentially done with this practice now. And so Shireen is with us full time and running her own practice. So if any of you are having trouble getting in to see me, you are welcome to see Shireen. She's awesome, super friendly, very knowledgeable, and highly skilled. So we're very excited to have her with us. Great addition to the team. So yeah, that's what's new and exciting. And I see the questions are coming up, so I will start answering those, and we can go from there. I'm on the video now too. I couldn't see myself before, but now I can. Okay, so for those of you who are watching, this is our show, Fertility Factor Fiction. We either have a article to review or we do just questions. Because I was away last week for holidays, I figured we'd just answer questions today. So that's what we're going to do for all of you. So I can see some of the questions. And here we go. So from Derek, what do you recommend for an estrogen producing likely follicular cyst? Wait for resolution or drain? So we would wait like 2 or 3 months unless there was a reason why you had to rush. And then if that wasn't working, you're either trying birth control at the same time, which is totally reasonable, or drainage or surgery. Drainage doesn't work very well because typically the cyst will come right back. So a lot of people don't proceed that. So that's the answer to that question. And it depends on what kind of cyst. Not every cyst can be drained. Some of them can be and some of them cannot be. So it depends on what we're dealing with. Is there any concern about doing a hysteroscopy 1 to 2 weeks after COVID? None whatsoever. I mean, COVID should have no impact on anything hysteroscopic. So you would be fine there. That would not be worrisome at all. For high NK cells, do you recommend any treatment after the first trimester of pregnancy? Use prednisone and intralipids during first trimester, but have since discontinued. Yeah, so it's interesting. I don't think anyone would continue steroids past first trimester because there is a concern about cleft lip, cleft palate, and also growth restriction. We do it in some cases where they have very significant immune problems, but otherwise, generally speaking, we don't. From the standpoint of intralipids, there's sort of 2 groups of studies. There are the ones that stopped at 12 weeks, and then there are some that continued on. So we typically will continue on with our intralipids until the patients hit about 34 weeks, 32 weeks in that time frame. So if you want to continue, you can. If you want to stop at 12 weeks, that's reasonable too. It's not super clear because there were no comparative studies of 12 versus 32, 34, 36. So either one is a reasonable option for you. Okay. Dr. V and T, how long after? T, by the way, is not with us because he's enjoying Egypt at the moment. So T, hopefully you're asleep right now, buddy. But we miss you. Hi, Dr. V and T. How long after stopping moxifloxacin used to clear uterine bacteria can I do my FET? I'll be taking my last moxifloxacin 7 days prior to the start of my next cycle. Yeah, so we would normally advocate for making sure that you are done and that you've cleared the infection. So if you've cleared it, yeah, for sure, you can go ahead. But that usually takes one cycle to test. So that would be very important. When should I start aspirin to prevent, I think that's preeclampsia, before you even conceive. So a lot of studies have looked at when to start aspirin, and we have a great video on it on our YouTube channel. And unfortunately, those studies are all hampered by the fact that they start people on the aspirin after they get pregnant. It's too late. The whole issue is that it's an imbalance between two chemicals called thromboxane and prostacyclin. And in order to properly establish that balance, you need the aspirin in you before you get pregnant. So start the aspirin, just stay on it before you conceive. I experienced fever of 38.5 second day after FET. Could that indicate an immune response to the embryo? That's impossible to know. It could be 100 different things, but certainly that would be reasonable. Can COVID affect TSH levels? Not that I know of, but the estrogen you're taking can affect your TSH levels. But certainly if you got COVID right before, I would definitely be concerned about that. So if you got COVID right before you were doing an FET, we always stopped and waited 2 months. Okay, back to YouTube. Hey, Dr. VNT, what are your thoughts on taking Lupron for endoadenosuppression, however you suffer from chronically thin lining? Any risks of lining not thickening after taking Lupron for 3 months? Yeah, I mean, Lupron alone before an FET is useless, so keep that in mind. It needs to be Lupron and letrozole. And we would always advocate for that. And then we have different tricks that we can use to thicken your lining. So it depends on sort of which way you want to do things. But for suppression for endoadeno, you need Lupron and letrozole for 3 months. From Facebook, hey, Dr. VNT, negative home pregnancy test, 12 days post 5-day transfer. Blood work in 2 days. Do I still have a chance? Yes. So the home tests are not always accurate, and so you do still have a chance. And we would always advocate for waiting till the blood test because otherwise you just go nuts. So there is still a chance. Would there be any concern with doing an FET in September cycle if I have COVID now? Yeah. I mean, COVID now is not as bad as it used to be, but we always tell our patients to wait 2 months. At what point in your cycle is it best to do an MRI to check for endo? You can do it at any point in time. MRIs are not that great at finding endo unless it's deep infiltrating endo. So if you have deep infiltrating endo, that's a different story. But if it's not deep infiltrating endo, MRI is kind of sketchy as to whether or not it'll find it. Well, here's a great question from Cortana Blaine. What would be reasons why REs don't remove fibroids in the uterus before an IVF? It could be because they're small and they don't have an impact unless they're bigger or they're distorting the shape of the cavity of the uterus. It could be because they don't have the surgical skills to do it and they don't want to send you to somebody else that does because that makes them look bad. Or it could be because it represents a gap in the time from when you see them to when you'll eventually get around to doing treatment. And this is the kind of more skeptical, cynical me. And they don't want to lose the opportunity to make money off of you, so they'll delay. And that's unfortunately a reality. It's not a happy reality, but it's a reality. And so a lot of places are actually telling patients, oh, it doesn't matter. Just like they say all the time, endo doesn't matter. Endo totally matters. There is no question whatsoever that endo matters. But a lot of places are being told or telling their patients endo doesn't matter. That's simply not true. Endo hugely matters, and you need to make sure that you are addressing it before you go through with any treatments. Great question. From LK on YouTube. Hi, Dr. V. What about ADHD meds? Yeah, so Like by Vans, we make our patients stop. We've had some very, very poor experiences with that and seen terrible egg quality, including in an amazing egg donor. So we absolutely make our patients stop. We do not let them continue things like by Vans. So that's an important one. Okay, from YouTube. Took letrozole for 3 months. FET September per your explanation. Does it mean letrozole plus Lupron before transfer? Having consult Friday, I need to advocate for myself. Took letrozole for 3 months. FET September. I'm not sure what you mean, Dorcas, but if you took Lupron and letrozole together, then you don't need to do it again. But if you have endo or adeno, you should be doing both for 3 months prior. If I don't have fluid in my uterus or lining, but I have some fluid in a small isthmusile, could this be treated or should it not affect? Oh, it'll definitely affect FET success. So we definitely recommend treatment, and that's important. We'll most likely do a natural FET, no estrogen, but vaginal progesterone. Only have one embryo. Oh, should I do a mock cycle? So I'm not a big believer in mock cycles because you can convert any cycle into an FET or you can cancel. So you don't need a mock where you're paying people for everything and then it doesn't work and or it works and then you stop. Like, why would you do that? If it's working, everything looks good, just go ahead. So I'm not a big believer in that. Hi, Dr. V. Is there any risk to doing embryo glue and actual transfer right after one another? Embryo glue is added to your culture media. You don't do it ahead of time and then do the embryo transfer. At least we don't. We add it right into the culture media, which is probably part of why the success rates are so high. We just got our results today. We hit our all-time high, 85.7% with one euploid embryo. So I'm very proud of that number. It's getting closer to 90. If I can eke it a little bit further forward, I'll be super happy about that. Thank you to my amazing lab team. Good job, guys. Good job. I love you all. Dr. V&T, good day. I took LH test at 8 a.m. and 4 p.m. at two different labs. Why is 8 a.m. LH 13 and p.m. LH is 8.5? I mean, it'll fluctuate throughout the day, so it could be that. It could also be that you spiked the day before and you're on a decline. Those would be my two reasons I would think of. Hi, Dr. V and T. 10 weeks postpartum and done with TTC. Wanting a solution to control endo pain or prevent regrowth. OB recommends birth control pills. What do you recommend? The pill is reasonable. Mirena IUD is reasonable. Depo-Provera is evil, but it's very good for the pain. There's Vizan if you're in Canada, which is excellent. You can do Lupron with Adbac. You can do Orilissa with Adbac. There's this new product called Myfembry. I've got little pamphlets here somewhere. Myfembry. So you can use Myfembry, which is Religulix and estrogen and progesterone all mixed into one pill. So those would be the mainstays of treatment. The birth control pill is like probably the most gentle. Vizan would be the next most gentle but more effective than just the birth control pill. So it depends on what you're looking for, Amanda, but there are a variety of options. Again, it depends on where you're living for what you have access to. PCOS, no periods without Provera. Postpartum 6 months, not breastfeeding. Should I start taking Provera to induce a period? Well, it depends on what your goal is. If you just want to prevent endometrial cancer and hyperplasia, yes, you should definitely take Provera every month, or the birth control pill. Either one is fine. If you are trying to avoid, or not avoid, if you're trying to conceive, you need letrozole. Getting a period, and I just had to explain this recently to someone, has nothing to do with getting pregnant. You must have an ovulation to get pregnant. And you can force periods using Provera, but if you don't release an egg, you're not going to get pregnant. So they're two different mechanisms altogether. I have a headache for 4 days, but my blood pressure is worried. My blood pressure is normal. 30 weeks, I'm worried about it. Yeah, headache in pregnancy can be very normal. But if it's 4 days long, I'd go get checked out. So you should go to obstetrical triage and have them assess you. How long prior to FET would I recommend someone stop their ADHD meds? At least a month or two before. The half-life is pretty long on that stuff. Do you think that inflammation, extreme pain from PIO shots can affect the embryo implanting or early pregnancy in any way? Pain, probably not. Inflammation, definitely. I mean, if you're activating your immune system as part of a aggressive kind of sensitivity reaction to the PIO, you're not going to do well. So those are cases where you definitely want to get checked out. Cool name from YouTube, 32 Hollister. I'm 13 weeks. Congrats. VRC is doing serial growth scans every 3 weeks. Since my dating scan, I've consistently measured a week ahead. I'm high risk and a 36-week induction plan. Will my due date be moved up? No, your due date doesn't get moved up. It's based on procedures if we did one. And so in that situation, we would not move your date whatsoever. However, I would definitely make sure that you are being monitored carefully, which you are. Obviously, that's great. And then at 36 weeks, we would deliver you, and that would be safe because it's fine at 36 weeks. So Dorcas, who asked the question earlier, said she only took letrozole for 3 months for endo. There's no data that supports using letrozole alone for 3 months for endo that I am aware of. So I'm not sure that that's an appropriate approach. It's Lupron and letrozole together for a minimum of 2 months. 3 months is better. I'm going back and forth between TikTok and all these other platforms. I am 19 weeks pregnant, thanks to you and your team. Yes. I have been on Vyvanse and have taken it daily for the last 5 years. Should I be stopping the Vyvanse? Once you're pregnant, we don't have a lot of data on Vyvanse for pregnancy, but it's recommended that you not be on it. But if you're on it, I would talk to whoever's prescribed it for you before you make any changes. But in terms of getting our patients pregnant, we tend to tell them to come off of the Vyvanse. But again, it depends on your history, and not everybody can come off of those meds. Hey, Dr. V, thanks for your response. Is there any risk of doing the FET 7 days after stopping the moxifloxacin, aside from the fact that the infection may have not cleared up? There is data that came out probably about 4 or 5 years ago, maybe longer, I don't recall exactly now, that suggested that people that were on antibiotics right before IVF treatment had a higher risk of miscarriage. There are other studies that refute that, so it's hard to know for sure. Do I think the mini pill is effective? We know the mini pill is effective, so that's an easy one. It's not as good as the combined pill with estrogen and progesterone, but it is good. Here's some interesting questions. Does intermittent fasting negatively affect egg quality that you have seen? Not at all. And there's no data to suggest that it is detrimental. In fact, weight loss, if it's an issue for you, definitely is helpful. Is cacao good for egg quality, better than acai berry? Well, there's no explicit data on that I'm aware of, but dark chocolate's good for a lot of different things and has a lot of anti-inflammatory properties, so it's probably not a bad thing. Took letrozole for 3 months for endo. Oh, this is Dorcas again. And BCP for 5 weeks now. Before transfer, do I take letrozole plus Lupron COS? Will be on Lovenox too. COS have had multiple miscarriages. Dorcas, you need to contact us and do a consult. None of that makes any sense whatsoever. So I would not be doing that. I've been on Dr. Pattinson's list for funded IVF since earlier this year. Planning to switch to you now that he retired. Where will I be fit in on your funding list? So we had 2 separate funding lists. I would recommend you follow through with his list because you'll just be inherited by Dr. Ray Hall. Otherwise, you'd be going to the bottom of our list. So I would stay with Dr. Pattinson. Can Plaquenil help with NK cells and cytokines? Absolutely. Very good for cytokines. Very, very good for NK cells. So we use that all the time for our patients. If you are a breastfeeding mom, when can you become fertile again to try for another baby? So while you're breastfeeding, you are relatively infertile. It is still possible to get pregnant, but it's much more difficult because your prolactin levels are high, which suppresses estrogen and often ovulation and makes the endometrium relatively unfriendly. Now, there are women that get their period regularly, even while they're breastfeeding, so that would be your best chance. But for everybody else, we generally recommend that they stop breastfeeding before they get going. What is the likelihood of having a natural pregnancy at age 40? About 5% per month, 5 to 7% per month. Depends on a lot of things, but that would be a reasonable number. Hey, Dr. V, how are your new clinics coming along? The lease is being signed for the second one this week, and the new one has its grand opening at the end of the month. So we're excited about that. Rose, endo-adeno patient, what should E2 be at for modified natural FET before you supplement with estrogen? So we don't pay a lot of attention to the estrogen levels. There's one study that said it should be a minimum of 100 picomoles, but I'm not sure that that's necessarily true, and almost everybody has at least 100 picomoles. So I don't follow the estrogen levels per se that closely. Like, we monitor them only to make sure they don't go too high. But if you're doing a modified natural FET, it's the lining thickness that's the issue. And so if your lining thickness is not sufficient, you need some estrogen or some kind of stimulation for your estrogen, for your lining. So that's the way we would do it. We don't pay attention to the levels, we pay attention to the thickness of your lining. That question got asked twice. What should E2 be at for modified? Okay, any preference to the oil mix for PIO? No. So there's peanut oil, sesame oil, ethyl oleate. There's a whole bunch of different ones. So we don't necessarily feel any one is better than any other. However, different people react to different formulations of progesterone. So some people react better to one, other people react better to the other one. So it really depends on kind of what they get and what kind of reaction. If you have high NK cells, how long before FET should you start on intralipids? Great question. So there are a variety of different protocols. We usually do 5 to 10 days before the day of the FET, and then when you get a positive beta, and then every 6 weeks. That's our approach. I have diffuse adenomyosis. I'm sorry. Can this cause infertility? Definitely. And what does treatment look like? Unfortunately, it's suppression for adeno. So you got to shut down your estrogen levels. So that's Lupron and letrozole. We use an immune protocol for those patients as well, and then try and help them get pregnant. You don't have to do IVF. There are natural approaches that work. We also use multiple supplements, NAC, coenzyme Q10, resveratrol, curcumin, and ALA. But it is harder when you have significant adeno, and especially when it's diffuse, it's particularly tough. Great question, Tina. Have you been running out of funding before April of each year? Oh, dear God, yes. Or are you likely to get your funding for your IVF cycle the same year you get on the list? No, we run out very quickly every year. We have way more patients than we do funding. So we're already out for this year. So yeah, we run out way early. Asking for a friend, what causes the drop from day 3 to day 6? I have no idea what you're referring to, SR medius. I have no idea what drop you're talking about. I need specifics on that one. And I think that individual asked the same question on TikTok and on YouTube. Is a non-elective 36-week induction called in at WRH before a 39-week elective? Oh yeah, definitely. Absolutely it would be. What age is too old to have a baby? So there was a recent study that suggested that older women, those who are over 45, had a higher risk of multiple complications and adverse outcomes in pregnancies. How old is too old in my opinion? Purely opinion, please don't get angry at me. And I have justification for this that I think makes sense, but this is purely my opinion and actually the opinion of our ethics board as well. 55. And the reason for that is that your child, on average, will only be in their early 20s when you are likely to die. not to be morbid, if you are having a baby at 55. And so while I believe everyone should have their autonomy and the freedom to choose what they want, we feel strongly that there are ethical implications for the children if you are getting pregnant over the age of 55, because you could be leaving a child without its parents or a young adult without its parents, and that has significant lifelong impact. So for us, it's 55, but that's what we do. But I don't think there's an age that's too old. I mean, we had someone that was 65 and was trying before the ethics committee said we want to implement an age limit. Do I advise DHEA for DOR? Does it help egg quality? It does not help egg quality. It does help egg number. And there is some meta-analysis data that suggests an increase in live birth. So that's kind of what we see and what we do. So yes, we use it all the time for our DOR patients. It's routine. Oh, here's a good one. What do you suggest to improve fertilization in ICSI IVF? Yeah, I just had this chat with my lab today because I'm always pushing them to do better and better and better. We have very good rates, but I always want them to do better. So you need the best people, number one. Then you need the best equipment, number two. And then you need to get creative. So improving the sperm, improving the egg quality, not overdosing the female patients with too much meds because you'll barbecue the eggs and that's never a good thing. Making sure that you don't, expose the patients to smoking, drinking, drug use lots of vitamins, anti-inflammatories, stuff like that. That's all really important to maximize your opportunities and your success. And then there are some cool things we're going to be trying, like adding progesterone to the sperm and the eggs, which apparently improves fertilization. We presented that on the show. So we were just talking about implementing that, and we will be trying that after some initial research trials here in-house. Embryo rate. SR Medius, I still don't understand what you mean by embryo rate. That's the drop from day 3 to day 6. Do you mean the number of embryos that make it from day 3 to day 6? That's purely related to sperm and egg quality, although the belief is it's more related to sperm than to egg. So if you're asking why there's an attrition, a loss of day 3 embryos going down to day 6, that's because not all embryos can make it. And the belief is that many of those are because of the sperm quality. I have a PGT-M probe. Geneticists said they were able to find only 5 downstream STR markers near the AR gene. 5, they say, may be inconclusive. Can you please recommend a geneticist to improve the probe? Wow. That's a great question. So, I mean, we use Cooper. They're the largest in the world. Probably the next biggest one, I think, is Juno. And they're quite good as well. But there's a bunch of different groups out there. So I would probably talk to Cooper. That's who we would go to first. You might want to speak to a geneticist. We use our own people, and we include it in every single IVF case that we do now. It's included. So they're called Genomic Care. And so, yeah, I mean, that's what we've done. And that seems to work out very well because our patients are well educated and informed. How long after an FET can you fly? Technically, you can fly the next day. That's not a major issue. But we tend to tell our patients to try and delay as long as possible. So if you can delay longer, that's good. You're welcome, June. My doc doesn't believe in a positive Receptiva DX test. Either do I. Doesn't believe in test overall. Wants to move ahead with FET. She doesn't think I have endo. What do I do? So I'm not a big believer in the Receptiva test either. There are newer tests which may or may not be better. We're just trying one out called Endomere. It seems to be reasonable, but all of these tests just give you a score, and that score is a percentage chance that you have endo. So it's not really like that helpful. If you're worried that you have endo, first you can figure it out by talking to a good RE or gynecologist. And then if you still suspect it and your doc's not listening, I would say take your embryos and go somewhere where they do listen. We always take endo very, very, very seriously. Endo is a major issue. People have a lot of problems with endo. They can't always get pregnant when they have the endo. And if you watch our endo video on YouTube, you'll very quickly understand that everyone who has ever said that endo doesn't matter is flat out either ignorant, lying, or just doesn't care. The reality is that endo has a huge impact on fertility, and anyone saying otherwise is just not reading or aware of the data. So that's simply not true whatsoever. So it is very critical to get your endo dealt with, and so we always advocate for exploring the opportunities. So you can either do testing, or you can just do laparoscopy, or you can be treated like you have endo but not know if you have endo, which I don't love doing because that's hardcore treatment unless you actually know that you have endo. Hey, Dr. V, quick question for a friend. Why aren't the friends here? I need more followers. Bring your friends. She had a hysterectomy, still has healthy ovaries. Would she be able to donate her eggs to a friend? Yeah, we've done that many times for people. That's not a problem at all. Would you treat elevated NK cells only 1 to 2% higher than the normal range? I'm worried to mess with my immune system right before FT. We would, but it depends on your history as well. Like, why did you have the NK testing? Did you know that you had a problem? Is there something else going on in your history that you're aware of? Like, why did you need to find out that you had NK cells? So obviously, once you find out, it's hard to justify not treating. So we would always advocate for that. I think we froze our questions on YouTube for some reason, and all the other ones, Facebook. Is it bad to have taken a shot of Lupron for endometriosis about 5 years ago? No? Why would that be bad? So Lupron, by and large, is safe and effective at controlling pain. There is a group called the Lupron Survivors Group, I believe. And they feel very, very vehemently, strongly that Lupron is the devil because many of them have had some extremely negative impact from what they believe is the Lupron. Now, the studies don't necessarily support that degree of intense negative reaction. But look, there are literally hundreds of thousands of people using Lupron every year. Are some of them going to have a terrible reaction? Of course they are. Same way somebody can have a lethal reaction to something as simple as Tylenol. So it is important to make sure that people understand that there are different reactions in different people. Is Lupron overall pretty safe? Yes. But are there risks? Yeah. There are risks, and some people will have adverse reactions. I've heard that Mounjaro helps regulate PCOS. Could taking this help or hinder getting pregnant? I have no idea what Mounjaro is. If somebody wants to inform me, that's great. If it's marijuana, do not use marijuana while trying to get pregnant, but I don't know what Mounjaro is. Is 170 nanomoles per liter too high for Proj heading into an FET? If you have endo, it would be on the high side, very high side. If you do not have endo, it's way too high. Currently on both SHOPS and PIO, I think they meant SUPS and PIO. I'm not sure if that's too much. That's too much. Mounjaro is like Ozempic. Thank you. So Mounjaro doesn't help PCOS any more than Ozempic does. Any of those GLP-1s does not help PCOS. Weight loss helps PCOS. So if you're losing weight as a result of exercise, diet, weight control, whatever you want to call it, or you're taking medications that controls it for you, that's good for PCOS. Weight loss, we know, helps women with PCOS. There are dozens and dozens and dozens of studies. But is it the medication that's helping you? No, it is not the medication that's helping you. I'm 40 with good ovarian reserve but high prolactin. Do you recommend IVF or try other solutions? I don't know enough about you to answer that question, but I will say that I only recommend IVF if people don't have any other choice. Otherwise, I always offer people all of their options and then let them decide. Treating prolactin is very easy. There's two different medications that are traditionally used, bromocriptine or Dostanex. Either one of those will work very well, and it'll get your prolactin down. If that's your only problem, and you have very good ovarian reserve, I guess I'd be asking why somebody would be pushing you straight into IVF. There's nothing wrong with doing IVF. It has a lot of advantages, including fertility preservation and your highest chance of success, making sure your miscarriage rate is lower because you can check the embryos to make sure they're genetically normal. But you don't have to go straight to IVF. You do have options. What dosage of NAC should I take for endo? We use anywhere from 1,000 to 1,500. How many months before FET? At least a month. We don't do the on and off thing. So they're asking, can you use the NAC on and off? And we don't do that. I don't believe in yo-yoing patients on anything. It's the same reason we don't use once every 3-day progesterone. SR Medius, I answered that question about do I have a preference for which oil is used in PIO? I do not. Whichever one you react to the least, is fine. Biochemical after following the endo protocol with VRC. Oh, I'm so sorry. Stage 4 endoadeno high NK cells. MRI showed lots of endo after suppression. Should I get another lab? There's advantages and disadvantages. I'd have a long talk with us if it's us that's taking care of you, or your fertility specialist if it's somebody else. But yeah, I mean, I would definitely be willing to discuss the benefits of it with you. And in your case, if you're having RPL with PGT embryos and you've done an immune protocol and done fertility testing, I would say a lap would be your only other option. Thoughts on Emma Alice? Should it be done ahead of FET? Depends on how many embryos you have, what your history's like. I don't necessarily promote Emma Alice, but some type of microbiome testing can be very beneficial to improve your success rates. And again, we're getting 85.7%. I've never heard of anyone getting 85.7% with just one euploid embryo. I spoke to a buddy of mine who also owns a clinic recently, and he's getting 80%. So, those incremental little changes might be what does it. I don't know. And he's probably one of the smartest people in the fertility world that I know, and I love him dearly. So I trust him as much as I trust anyone in my own practice. Would a ferritin level of 44 qualify for iron infusions? No. No longer able to stomach Ferromax while pregnant and quite symptomatic. You wouldn't be symptomatic from a ferritin level of 44. They won't even transfuse you unless you're less than 15 when you're pregnant. So 44 is way too high, and you would not be symptomatic from 44. Will 43 years of age with adeno managed through Vizan still be a good age for embryo transfer? Yeah, sure. My AMH at 40 is 2.5, but my grandma had menopause at 43 and my mom at 47. My menarche is at 12 PCOS. So June, you're going to be different because you have PCOS, but your age is not relevant. Your adeno would be. And embryo transfer, if you already have embryos, means nothing because you made them earlier. If you're making new embryos, your age is going to be a bit of a problem because you're going to have a very high rate of aneuploid embryos, but that doesn't mean that you can't proceed. It just means you're going to have to try harder or more times. Could being methyl tetrahydrofolate reductase enzyme homozygous positive, that's for a mutation, be a cause for RPL? Definitely. Treatment, methylfolinic acid instead of folic acid, aspirin and heparin. Treatment's easy. Undergoing IUI with FSH injections, and my follicles are growing quite slowly, less than 1 millimeter per day. Currently on cycle day 13. Yeah, I mean, that's a little slow. IUI is different than IVF. With IVF, we want your eggs to hit maturity by about day 11, 12, if we can. So yes, that is a bit of a problem, but it's not the be all and the end all. And there are cases that will succeed. You can always tell them to give you a little more FSH. That would be totally reasonable. Hi, Dr. V and T. When is LIT done for an FET? Minimum 2 to 3 months before, so that you can retest and make sure your levels are appropriate. Repeating questions from others on IG. Any studies on the efficacy of infrared light therapy for fertility? Yeah, there are. And there are studies that suggest that it's beneficial. I don't believe any of them because it seems way too hocus pocus for me. But there are studies that suggest it's beneficial. They're not well done studies, but they're there. Okay. Based out of the US, how can I work with you on an FET? What's the timeline? So we'd start with a consult. We do this for tons of US patients. We'd start with a consult, which we do via Zoom, kind of like this. We would then talk to you about where you should do it, because I don't force patients to come to us. If we can help you where you are, that's great. If we cannot, then you're coming to us. Timeline depends on what's wrong, but anywhere from a couple of weeks to a couple of months. It's not particularly difficult. Can endo cause RPL? Yeah, great question. Very, very good question. So the answer to that question is endo does increase the risks of miscarriage. I've never seen anything that says that it increases RPL, but it does increase the risk of miscarriage. So yeah, it probably could increase RPL ultimately as well. But we don't have any data that suggests sort of definitively that it's an RPL cause. And we certainly don't tell patients with RPL to go run and do, laparoscopic surgery to rule out endo or the endo tests. Is there another test more accurate than ERA? The ERA test is useless. It is not accurate whatsoever. In fact, it was proven to be entirely incapable of detecting endometrial receptivity. So there is no test more accurate than an ERA because the ERA test is not accurate itself. Do not do the ERA test. It is a useless test. It is proven to be useless. Don't bother. Any advice if I had multiple miscarriages, 3 back-to-back? First of all, I'm very sorry you experienced those miscarriages. That's terrible. Advice, I would definitely follow through with someone you trust and get appropriate testing so that you can understand why you're having the miscarriages. 3 back-to-back from every guideline I'm aware of is the standard for additional testing to rule out a problem. My first FET failed on a natural modified with euploid embryo. My RE wants to repeat same protocol without any changes. What do you think? Depends on how many embryos you have. Not every embryo will work, so it's not unreasonable to do the same thing. There's a very good study done by Richard Scott's group, which demonstrated that if you just took everybody and they didn't do any fancy testing, any fancy treatments, nothing, they just took patient after patient after patient, and they just kept transferring in euploid embryos. Within 3 euploid embryos, 95.2% got pregnant. And after 5 euploid embryo transfers, 98% got pregnant. The problem with that is getting 3 euploid embryos is very difficult for some people, especially if age is a factor, and extremely costly for some people. So it's a great study, but it's not necessarily a clinically practical study for everybody out there. So if you want to find out what's wrong, we would always offer additional tests. And in our practice, because our success rates are so high with 1 euploid embryo, I would offer testing to people even after 1 failure. And I do. I don't promote it, but I'll offer it. And it certainly depends on how many embryos you have left. If you have 10 more embryos, you probably don't need to spend a fortune on testing unless you failed again. But if you only have 1 more embryo, yeah, of course we want to do testing to make sure that we've dealt with everything before you go. If having pregnancies close together, do I need to get the Tdap shot again? No. The Tdap shot is of minimal value. 13 per million babies get sick to the point where they're hospitalized or there's significant morbidity or mortality from pertussis, whooping cough. So we are vaccinating 999,987 people unnecessarily to protect 13 babies who do get miserably sick and sometimes spend a long time in the hospital, but the mortality rate's negligible, and that's a lot of people to vaccinate for no reason. So I have trouble with that one, but I definitely wouldn't do it again if it was close together. Can I please explain the difference between a natural and modified natural FET? Natural is you take nothing, and then modified now has multiple different meanings. So it could be using letrozole, it could be an HCG trigger, or it could be doing it with progesterone. There's different meanings for modified natural. But natural is just natural. You wait for your LH surge, you wait 7 days after the surge, and then you pop in the embryo. Most people will still advocate for using additional progesterone, but that's where you start. Is ovarian PRP and human growth hormone good for rejuvenating eggs? Yeah. We don't know. Human growth hormone is for helping make more eggs. There's no question about that. It's proven now in multiple meta-analyses. PRP, there's several studies and several meta-analyses now. Meta-analyses are based on crap studies, so that doesn't help us at all. The 2 randomized controlled trials, one showed more eggs and higher embryos and better quality not better quality, sorry, more highly graded embryos, but not an increase in live birth. The other one showed no difference whatsoever. And so there was no benefit. And then one of the same authors, Richard Scott, who I mentioned earlier, brilliant guy, love him. He also did the randomized controlled trial. But before the randomized controlled trial, which showed no benefit, he did a cohort study with 500 and close to 30 women in it. And in that trial, they showed a 15% live birth rate in women that previously had no success. So the question is, would you get 15% live birth if you just took 500 women in menopause and just kept doing IVF to them? And the answer is maybe. So we don't know how good PRP is. I definitely talk about it at length with my patients. And unlike some of the other places out there, we don't push PRP on our patients. We talk to our patients about it. We offer it to our patients. Patients that come here and they say, I'm 43, I'm 45, I want to do PRP with you. I tell them not to bother because you still need an enormous number of eggs at that age to get a genetically normal embryo, and the PRP does not change your egg genetics. So it can help rejuvenate the ovaries in certain cases, and I've seen it work wonders, but it's not for everybody. What medication do I recommend for FET if you have Epstein-Barr and human herpes 6? Valtrex for about a month. I had my first lit treatment today. I'm not having a reaction. Does it mean it's not working? No, not at all. First of all, it's too early. It takes a couple of days to react. And second of all, not everybody gets a reaction, so don't panic. Can I talk about folic acid versus folate? Folic acid and folate are the same thing. Folinic acid, 5-methyltetrahydrofolinic acid, is the one you want if you have MTHFR. They're just slightly different, but there are some people that cannot process the folate because of the MTHFR mutation, so they need the folinic acid, which they can process. There is a big account saying that methylfolinic versus folate doesn't make a difference. They're probably wrong because they're not understanding basic biology. Does being on an SNRI, that's Effexor, versus an SSRI, Paxil, Prozac, and so on, affect being a candidate for an egg donation? Yes, you cannot be on an SNRI when you're doing an egg donation. You have to be on an SSRI, preferably nothing, because they all have some impact on egg quality. Do you think my Mirena IUD could cause inflammatory symptoms to joints, increase migraines, and fatigue? Yes, all of those were things that they found in the original studies, so those are all possibilities. Hello, Dr. V. What is your preferred ferritin level? I'm at 28 and goals to start stem meds in 2 weeks for IVF in September. Over 100 is ideal, definitely over 35 as a minimum, so I'd get that higher. Dr. V, what does the research say on HCG wash? About a 30% increase if it's done 15 minutes before your embryo transfer. So that's what we do. Based on my previous experience, how effective is PRP for people with POI? Not great. It really isn't great. If you have premature ovarian insufficiency, it does help, but you got to be young. If you're like, it depends on what you're considering POI. We get people that show up who are 40 and they say, I've got diminished ovarian reserve. Well, at 40, you don't have diminished ovarian reserve. Your ovaries are naturally getting weaker, and that's part of the process. So, is it useful for women who are older? No. Is it useful for women who are younger, like they're 32, and they have premature ovarian insufficiency, which is like a true premature ovarian insufficiency? I do believe in that case it is. And I've seen it work pretty well in that group. Can you explain what steps could potentially be with an abnormal uterus? What steps could potential be with during my HSG, they concluded I have a unicornuate uterus. Not sure what your question is, but we wouldn't do anything for a unicornuate uterus. Most of those patients have very reasonable pregnancies with a high risk of the baby being upside down, so you may need a cesarean section. Radine, how are you? T is in Egypt. So he's not here tonight. So I'm one man, one woman show, but the woman is silent on the other end, running all the things I'm asking. So I'm reading out questions, which is why I'm looking sideways all the time, because there's two columns on my computer screen. I have 4 fibroids, which are all less than 3 centimeters each, approximately. They are not invading the cavity. Should these be removed, as there are so many? I would need to look at your uterus. Most studies, including the meta-analysis by Elizabeth Pritz and her group, suggest that they need to be more than 4 centimeters in order for them to need to be removed, even if they're not deflecting or manipulating the shape of the cavity. But I would want to do a detailed SIS to see what's going on for you. Thoughts on low-level mosaic embryos? Is there a certain genetic defect that you recommend to not transfer? Nope. There's this great study from Juno Genetics where they transferred over 9,000 mosaic embryos. And they didn't tell the doctors that they were mosaic, or at least the doctors were blinded to it. And then they looked at the results. The low-level mosaic embryos had the exact same outcome as genetically normal embryos. Now, granted, their success rates were way lower than ours, way lower, 30% lower. So I don't know that that works for us, but we are absolutely willing to transfer low-level mosaic embryos, and we don't even report them. We just report them now as being normal. Is lid therapy beneficial for low LADs, especially with multiple failed implantation failure? Yeah, so there's a wonderful meta-analysis we reviewed a couple of months back, which showed a 45% increase in live birth in people that do lid therapy when they've had previous failures. So yes, it is clearly very helpful. Do I recommend taking Valtrex before or after FET? You have to start it before and stay on it through your FET. Oh yay. Well, I hope he enjoys Egypt for both himself and I. Me too. T is the best. I love the guy. What is the best IUD on the market right now and why? Oh, great question, Radine. So I've always loved the Mirena IUD. I think it's a great product. There's another version of it called Kylena, which is not quite as strong, doesn't have quite as much progesterone in it essentially, so it leaks out a little bit less. Either of those two are great. The Mirena works very, very well. Side effects are spotting for quite some time, but then most women stop getting a period. It's great for pain. It's great for periods. It reduces the heaviness of your periods. And it is the most effective birth control on the market with a 1 per 1,000 failure rate if inserted properly. I do all of mine with ultrasound guidance so that we know exactly where it's going. But that's how we do it. Oh, I gotta do something on TikTok. Sorry, guys. We're almost at 9. Okay. Do you recommend retesting microbiome after endometriosis treatment? Absolutely. Does not make sense whatsoever at all to not get your microbiome checked. What is the success rate for having uterine PRP and intralipids for transfer? It depends on a million different factors. Your microbiome, your immune system, all of that stuff. However, from the standpoint of improvement in live birth when you do PRP for unexplained failures, it's a 50% increase. It's huge. So it does make it an enormous difference. In an ideal world, God knows we're not in an ideal world. How long would you like U.S. patients to plan to stay in Canada for an egg retrieval if staying nearby and monitoring with you is an option? 1 day. You don't even have to stay in Canada that day. If you're staying in Detroit, that's fine. Why are some miscarriages missed and some spontaneous? Does the cause of miscarriage play a role in that? Okay, let's briefly talk about miscarriage. You know what? This is a great video. I'm going to make a video on this. There are different types of miscarriages. So the main categories relate to, is your cervix open or is your cervix closed? So if you have a closed miscarriage, you have either a threatened, which is bleeding, but the baby's still alive. So it's called a threatened miscarriage. You have a missed miscarriage, which means the baby is no longer alive, but you have not had any bleeding or any symptoms, which is why it's called missed. No cramping, no bleeding. Or you have not necessarily a miscarriage, but there's an ectopic, or you have a molar pregnancy, or something quite abnormal is going on. If your cervix is open, you've either had an incomplete, meaning some tissue has come out, but some of it's in there. You've had a complete, which is where everything has come out and your cervix is still open. Or you have an inevitable, which means you haven't passed anything yet, but you will. So those are the different types of miscarriages. The only other one is what's called a septic abortion, which doesn't really exist anymore, although it might be making a comeback now in the US. Who knows? I haven't seen any studies on that. But that's in the days past where people didn't have access to abortions, and they used to do what was called the coat hanger abortions. And obviously they were getting sick from that. So they would get septic, and then that would cause a miscarriage. It was an intentional miscarriage, but the sepsis was the problem from that. Okay. Have I dealt with progesterone sensitivity on my periods? My eyes swell shut. Wow. No. I've read about it, but you would literally have to be on some kind of progesterone blockade for that. That's awesome. What do you treat uterine staphylococcus with if there's a penicillin allergy? I can't speak personally to you because I don't even know who you are. I'm just seeing a question written here, but our go-to in our practice is moxifloxacin. I think I answered all the questions with 2 minutes left to spare. Cool. Anybody have any last minute questions? Because I'm going to sign off. I got 4 hours of sleep last night and desperately need to go rest. Oh, here we go. What's the percentage chance of someone getting pregnant if their period isn't regular? Poor. And there's no way to answer that, but it would not be good. It would be very low. Any other questions? If you do not PGT test embryos, but they have the same grading, how does VRC decide which one to transfer? That's a great embryology question. The embryologist decides based on what they thought about the embryo when they looked at it. And they have their own recall and grading system and so on, but there's no difference between two untested embryos. You could, however, do the artificial intelligence, which is a ranking system and does not require that you biopsy the embryos. I'm not sure if T is back next week. He told me he was off for 2 weeks, but God bless you as well, and thank you. I will answer one more question. I've done 2 embryo transfers and both failed. I am so sorry. I have 1 embryo left, not PGT tested. I feel like it's an implantation problem. What protocol is best for implantation? Doesn't work that way. I would need to see you, and I would need to make sure that we know what's wrong. And then we can figure it out. There's no protocol that's best for implantation. I mean, there is, but in situations where you do embryo transfers and they fail, we need to find out why they're failing. Dr. V, is the absence of Tarek the reason why I can't find last week's video of fact or fiction? I have no idea. I'll ask T. Oh, no. Last week, there was no video. I'm sorry. Last week, there was no fact or fiction because I was on holidays. I had a much needed break up at my cottage. Some of you may have caught me video recording on Instagram while I was paddleboarding because the people were getting confused about our endo video clip where we talked about the fact that Lupron alone is not useful prior to an FET. It has to be Lupron and letrozole. Okay, so it's 9 o'clock officially. Thank you very, very much for watching. We love you all. Thanks to Natalie for helping out with this. T, God bless you. Be safe out there, buddy. And I will see you guys all next week, Tuesday night, on Fertility.